And what is this all about? It's to ensure that we empower our patients with knowledge, because we believe that if patients are aware of the process they are going through, that they will be part of the journey. They will be able to ask the appropriate questions. They'll be able to be less agitated, be calm while they are going through the process, because they have an understanding of what the process is all about. We also try to be very transparent. So we tell you everything about the whole process, because we're aware that a lot of you, your journey did not start here. Your journey started somewhere else before you came here. And by reason of you having engaged in this journey, you've acquired a lot of knowledge. And so we also want to acquaint us with the process as it obtains at the Abebe Fertility Center. So I'll be taking all of you through the journey. All right. All of you are all seated here, but you all have different processes, different treatment programs. All right. I will try and cover as much as possible all that we do. And then it's also going to be an opportunity. David, this thing is not working. No? Just turn to the next this thing for me, please. Next slide. Okay. So what we have promised at the Abebe Fertility Center is excellence and quality fertility care. All right. And that is the commitment we owe all of our clients. But we believe that to be able to provide this quality care and to serve our patients well, we need to have our patients empowered with knowledge. All right, because I like patients who engage me in the clinic and ask questions. So when you come in and then I say, any questions? And say, well, doctor, no for now. Okay, fine. The patient who comes and has a list of questions he wants to ask, I say, this patient has, this is my friend. She has researched, she has put down things that are bothering her. And when she comes to the clinic, she wants to ask her doctor so that she feels a part of the process. That is what we want here, all right? So they should know what to expect, and then thus we are getting your full cooperation. Now, this platform is also going to provide you the opportunity to ask questions, all right? I'm sure that there's a lot of questions that you probably will be having as it has to do with this journey to parenthood. Please, any question, no question is off the platform, okay? Any question at all, please feel free to ask, all right? And then what we're going to be doing is to lay down a very concise process, okay, through which you're going to become parents and have your dream fulfilled. All right. Next slide. Am I supposed to turn to this place or turn to this place with my pointer? Oh, no, you have gone further. Okay. All right. Okay, so I'm sure that a lot of us have gone past this process already, okay? But just for the benefit of us having knowledge, because we also want to ensure that we make you guys ambassadors of the Abebe Fertility Center, because I'm sure you have friends, you have colleagues, people who probably may want to also come in and be part of this process, all right? So at the beginning, you start off with your registration and consultation, which I'm sure all of you here have gone through already. All right. And then after that, you go for your investigations. All right. And then you have a result review. And then at that result review, your treatment options will be discussed. How many of us did not go through this? Okay, that's what you came for today. Correct. So after this, you will have your result review. You must go through the process. You can't shunt. If you try to jump, it will not be well, because every process is important, all right? And so you have your result review, and at that result review, as you will get to know, we will take you through your results, and thereafter we will not discuss the options We will lay the options open to us. As much as possible, we want patients to be part of that discussion so that when we decide on what option we are choosing, it would have been a joint effort, all right, so that you're part of it. And what we will do is to, based on knowledge and experience, we'll try and guide you as to which option we think is most successful, what the different treatment successes are for the various options. And so once we have done that, then once the payments have been made, you would now go on to have your treatment program planned, and then to be sent to you. You'll be counseled, and thereafter, for those who are not in Abuja, you have a call from us, and your program will be discussed with you. Now again, how many of us have gotten our treatment plan? Some of you have gone far, so I believe there are some of us who have gotten our treatment plan. How many of you have gotten your treatment plan? Okay, you have your treatment plan, fine. How many of you were called to and they explained the treatment plan to you? Or you just saw it on your WhatsApp and then you went through it and then there was one voice note, one voice message that came with it. How many of you listened to the voice message? And how many of you understood the voice message? Everybody. Okay, now, how many of us did not understand the voice message? Aha. Aha. Okay, but I need to find out what level are you? Have you had your treatment? Have you had your result review? Yes. And when was that? I was there like last week. Okay, last week was when you had your result review. Okay, last week. So the next plan for you is once you have completed your additional payments, you have, so we are the ones that will now respond by sending you your results, your treatment plan, okay? And then once that is sent to you, now what we advocate is that for patients who are in Abuja, we'll prefer you come to the hospital, have a sit down with us so that we can discuss, counsel you on the treatment option, on the treatment plan, take you through the whole process, okay? And what does the treatment plan contain? Now, the treatment plan contains the flow of your program. It contains dates. For example, when your menstrual regulation will start. For most of you who have gone far in your program, you'll notice that we started you on something like level fem for you to see your period at a certain time. It will contain the date for you to come in for your injections, Zoladex injection for those who are on recipient programs, or for those who are self-programs, it will tell you when you have to see your period, and then when you have to come in for your scan, your mock embryo transfer, and all of that. And so all of those things are all explained to you. Now, it's very important for us to note that we emphasize that this treatment plan is, those dates, they are very tentative. Please, they are very tentative. Why do I say so? Because there are so many things that can alter that plan. For example, if on that plan we said you're supposed to stop your menstrual regulation on the 5th of July and see your period on the 9th of July, if your period comes on the 12th of July, it has altered the whole program. If it comes before that time we put there, it has altered the program. Not just that. For patients who are on recipient programs, when I mean recipient, I mean those on egg donation program, there is a whole lot that goes between when you start your program and you start the endometrial regeneration and when your husband is called to come and produce. Why? Because we are trying to synchronize two arms of your program, your preparation of your womb and getting eggs for you. If both of them does not come into the same alignment, we cannot call you. And sometimes it takes time for us to get those two to come into alignment. And so, but the good thing about it is that once you have been down-regulated, we will get to that. If you have taken Zoladex injection, What that injection does is that it helps us to take control over your body system. So if you have taken Zoladex, you cannot ovulate. We can stretch your period, your cycle from your normal 28 days, 25 days, 30 days to as much as 40 days. And you will not see period. Why? Because we're in control. And that is the reason why for every woman who is still seeing her period, she must undergo down regulation. All right? Yes. And so that is what the treatment program is. And then everybody, for those who are not based in Abuja, you are supposed to get a call from us. After you have been sent your treatment program and they've sent a voice note, you have to get a call just to make sure you understood what has been sent to you. Please, if you get the treatment plan and the voice notes, if we don't call you, call us. Now, every patient, by the time you are doing your treatment review, your result review, and the option being discussed, at that visit, you should be going home, not just with the number of the front desks, but with the number of the nurses. At that point, the nurses become your vital, they become your relationship managers. They are the ones who guide you and take you through the whole process. If you don't have the nurse's number, you will have issues. Because they are the ones you need to be calling. Only if you call me. I don't have your program in my head. There are patients who will send me a message and say, okay, what next? I said, call your nurses. Call the nurses. All right? So please, it's very important. Make sure you get the number of the nurses because they are the ones who would guide you. All right? Now, after your treatment program has been discussed with you, there's one very important part of this whole process that must take place, and that is this consent form signing. Now, for those of us who have gotten our treatment program and have started our program, how many of you have signed how many of you did not sign a consent form? Your hand up. Aha. 2. Okay. That's wahala. Now, you have started your program. You started scannings. Yes. And you've not signed consent form. They didn't give you consent form to sign. The first one and the second one, you didn't sign anything? No. Jesus. Even you too? Ah. This is our first time hearing. This is the first time you are hearing about consent form? Yes. Interesting. Anyways, we will deal with this matter afterwards. Please, all right? The program that you are doing, you have to give us the authorization to do it. All right? So that means there's been a serious breach in protocol. All right? The team ought to have given you a consent form to sign. And part of the reason why you sign that consent form is that you also need to know what program you are doing. All right? And that is why you are supposed to come in. For those of you who are in Abuja, you come in, have a sit down with the nurses or with the doctors, and they will take you through the whole process because some of you here, your programs are different. No two persons have the same program, trust me. All right? So based on the program that we have decided, they will take you through that program and you will have your consent to go ahead with the program. Okay? And then after, now, for those who are not in Abuja, we expect that before you start the program, when we say start the program, the main program actually starts for those who are recipients once you have taken your Zoladex injection. So if you are still on the menstrual regulation, you are still within that window of coming in to have the consent form signed. But once you have taken your Zoladex injection, then it means that the program has started. For self patients, before you start stimulation, the consent form should have been signed. Now, for those who are not based in Abuja, because that is where we have a bit of a challenge, there are some who will come in their first appointment. They're coming in for their for their consultation. They're coming in for their investigations. We are doing their mock embryo transfer, and then off they go. The next time they are coming, they are already far into their program because they would have started off at their base. Now, what we are saying is that at that first appointment, before you leave, you must, by then, would have known what program we are doing for you. You should sign the consent form, all right? So that we have that authority to go ahead and carry out your treatment program, all right? So the nurse is supposed to take you through that process, through the treatment plan, and thereafter you will sign the consent. So please, for those of you who have not signed this consent, after we are done today, we will all ensure that we rectify all of this. Now, this is part of the reason why we are having this, just to ensure that we share the knowledge, the whole process, make it very open and transparent, so that if we are not meeting up with our own obligation, you will help us to say, see, look at what MD said. I've not done this, I've not done this. This have not been done for me, okay? Okay, so after you sign the consent form, the program has been planned, it has been explained to you. The next thing is menstrual regulation. All right, majority of you, particularly those who, both the self and the recipient programs and the FETs, would have gone through the menstrual regulation. Now, in the menstrual regulation, you are given a pill. A lot of you probably it's Levofem that you took, or Primolut N. What is the purpose of this medication? Is to be able to synchronize and to make you see your period when we want you to see it. All right, and it also does help to also begin the part of the process of treatment to down-regulate you. All right, and so we will decide what you are taking. I had a patient who said, my friend said she's taking Levofem, and me, you gave me Primolut N. Why? I said, what's your friend's name? She said me, what's your name? Are you the same? No. So your programs are different, all right? And that is why it's not wise to compare programs. To say, oh, this is what they did for my friend, I also must also do the same thing. Your programs are different, okay? So based on the patient's profile, we will decide what medication to use to regulate your cycle. Again, some patients don't see their period regularly, and so they must get something to make them see their period. And some patients have stopped seeing their period. They've stopped seeing their period. The good thing about this is that we can make you see your period when we want you to see your period, and then we can start the program. All right, so that's the menstrual regulation. So that is the phase. So after we have done your menstrual, you have started your menstrual regulation, then you'll be told in that plan, you'll be told when you are starting and when you are ending. Please end when you're supposed to end. Anyways, the drug will finish by the time you're supposed to end. We don't give you excess, because I know some patients don't look at that plan. Even if you look at it, they are forgotten. They just keep taking the drug. All right. So what we do is that we give you enough to make sure that by the time that drug is finishing, you're supposed to have stopped it. And what happens once you've finished your menstrual regulation? You are supposed to see your period. Now, for those who are recipient patients, I mean, they're using an egg donor, or even those who are not even, for those who are using an egg donor, you are supposed to take an injection on the day you end the menstrual regulation. The last day that pill, the Levofem you are taking ends, that day is the day you're supposed to take an injection. If you don't take that injection on that day, or you skip it, it means that we are not in control of your body. And if that happens, and we don't know, the chances that you will get pregnant has it's gone very, very, very low. And so you are supposed to be told and explained to in that program that on this day, and to be written there, that is perhaps one of the days that is very accurate. It doesn't, that date is not tentative, except we deliberately call you and tell you, extend your pill to this new date, and on that date, come for your injection. If we don't call you on the date that that injection is given to be taken, that is the day it will be taken. If you are in Abuja, you come to the hospital and you have it taken. If you're not in Abuja, we would have shipped the drug to the injection to you already. All right. And on that day, you go to get a nurse who will give you that injection. It must be taken on that day. Why? If you don't take that injection and you go to and you see your period, it means we have lost control. And once we detect that, because it has happened to a few patients, we start the program all over. We can't take the risk of taking you through on this journey without being in control. All right, so
like doctor, the last time, after the first one I was playing, I was using Levofen.
Okay.
The second one I was using from net pain.
Yes.
But on the process, I've not finished the summer period.
Yes.
Before you now recommended I should start Levofen again. Then finish up with the net pain. Before that makes my own extended to this July.
Now, patients are different. There are some patients that break the rule. Yeah, they're supposed to be on this medication, and while you're on it, you're not supposed to see your period. Yeah. Now, it also depends on when that Levofen was started. If it was not started at the beginning of your period, then there are chances that when you start it, because you've not had enough time to take control of your body, you will still go ahead and bleed. But I've seen some patients who started on the beginning and yet they still bleed. Everybody's system is different. So once we notice that, and it's just for a few categories anyways, once we notice that, we have to now readjust our plan and then get out a plan that is suited for you, yes, for the body. All right, so we use Zoladex. So many of you would have taken Zoladex or will take Zoladex. And there are many, we also use Buserelin. Now, you notice that for some people who have done this program, who are on this program, after you have taken the Zoladex injection, the Zoladex injection, it's supposed to last for 28 days. It's a depot injection. Now, the reason why we use Zoladex and not the Buserelin at the beginning is because we don't want you to be coming for injection every day. The Zoladex will last for 28 days. You take it once, and that's all. The Buserelin is supposed to be a daily injection, and so it's usually quite cumbersome to be taking injection every day. So that is why we give the Zoladex. However, if we have not completed or gotten to a certain point in your program, we will, and it has gotten to 28 days, we will call you back to continue with the Buserelin to maintain the down regulation. All right? So I just want you to just know that. So don't say, but I was told that I will only take the Zoladex. No, you can take the Zoladex alone, or you can take the Zoladex and the Buserelin together. However, for patients who are on stimulation, who will be stimulated because we are going to want to use their eggs, you will start based on the protocol we are using. Now, we have different kinds of protocol. We have what we call the long agonist protocol. Don't bother about the name. I just say to mention it, that there are different kinds of protocol. That is beyond the scope of this presentation. But we have different kinds of protocol. The protocol that we use determines when you take your injection. Now, the protocol we are currently using right now determines that you start your injection on day 2 of your cycle. Meaning that you see your period, we ask you to come book an appointment to come the following day. When you come that day, we will do a scan for you to make sure that you don't have any cyst. On that same day, you will do a mock embryo transfer. Now, before I go on, I will get to that, but let me just ask, how many of you have done your mock embryo transfer? For those of you who have started stimulation or have started scanning. How many of you have done your mock embryo transfer? Okay? That one, we can't miss that one. You must do that one. It's either done in the office or done in the theater. So that must be done. So when we get to that one, I will explain more about what the mock embryo transfer is all about. So, but just note that, please, for patients going through this program, if it's a safe program, you will start 2 injections on the day of your stimulation. That's day 2 or day 3 of your cycle. All right? Now, if it's only 1 injection you are giving, it means that we have changed protocol. The current protocol we are using right now dictates that you start 2 injections at the beginning. But we are making plans to change the protocol. That's why I just mentioned that the protocol we want to start for the next set of people that will be coming will mean that you start 1 injection first, and then after like 5 or 6 days, another injection will be added. That's called a short antagonist protocol. All right? So it's very important for us that we know this, that once you have started your menstrual regulation, once you see your period, you are supposed to come to the hospital. Please, it's very important. We had a patient who was given menstrual regulation, saw her period, did not come to hospital, did not do scan, and then she was only called when her Zoladex had expired to come and continue with Buserelin, for us to discover that this woman, she had not even come to the hospital to even start scanning. Do you understand? We have our own parts. I blamed, when this happened, I had to call our own people, and there was some miscommunication on our own part. But the reason why we are going through all of these is to also make you understand, that this is the process. So when we don't call, because you have been informed that this is how it should go. Okay? Once you have seen your period, call the front desk to book an appointment. All right? Your program begins properly once your period has started. Okay? And so, what will happen when you come? Okay, also very important to note that once you have stopped your menstrual regulation, your period comes after 4 to 5 to 7 days. Doctor, I've seen my period, I finished my medication yesterday, I've not seen my period. And you won't see your period. It doesn't come immediately. All right? So once you have stopped the menstrual regulation, it takes between 4 to 7 days for you to see your period. But once the period comes, it starts. The next day, book an appointment to come to the hospital, all right, to begin the process. And when you come to the hospital, what are you coming for? You're coming to have a scan. You also have a mock embryo transfer done. For those who are starting, this is your first time with us, you are starting a program, you will have a mock embryo transfer done. Now, this may sometimes be done in the theater. Normally, it is done in the office, okay? But sometimes if we do experience difficulty in assessing your womb, then it will be done in the theater. Now, why are we doing the mock embryo transfer? We want to be sure that everything is fine. We don't want to be taken unawares. Oh, we have embryos to be transferred into your womb. We get to your womb only to realize that the womb is blocked. We cannot access it. That becomes a major challenge. And whatever we want to do to unblock your womb, we can't do it there and there, because on the day of transfer, we don't want your womb to go through any stress at all. All right? And so if there's any challenge, it's better we detect it long before the day of embryo transfer. And that is why this is done.
Like me, when I done my mock, that was the first time coming here.
Yes.
And this was our first time after the text and the scan. I was asking if there is any scan. They said that there is more that will do, but since we are coming from it, that they can do it for me.
Yes, so we do. So I was going to come to that. Now, for the mock embryo transfer is normally done when you're about to start your program. Once you see your period, like I've said, then you do your mock and then you start. But for those who are not based in Abuja, are out of town patients, we do that when they come the first time. The reason is because we want to save you time and save you money. Because if we don't do it, you will need to come back the day you see your period. And that means you will stay in Abuja for the next 2 to 3 weeks because of that. But if we do it when you come the first time, once you see your period there, you can start off your medications and then continue. All right? So once we've done it once, it's okay. It's only when you have delivered or you've had the surgery. Now, there are patients who we have done mock for and they've had to go do mammectomy. When they come back, we need to repeat the mock because the womb may not be the same it was before we did it. Okay? All right? It's also very important for us to also note that sometimes for patients who we are going to stimulate, when we do a scan for them and we discover that they have a cyst, we need to drain that cyst before we start stimulation. But if we don't drain the cyst, the ovaries will not respond well. All right? That cyst will overshadow the whole response of the other follicles. And so we must ensure that we drain this. Unfortunately, the cyst drainage attracts additional costs. So when we tell you this is the amount, just put some jara in case we need to do something like this. Or when we need to do the mock in theater, that will attract an additional cost. Just to let us know. Okay? But not many people get to do this. Like I said, not two people are the same. I don't understand what is happening. Okay. So after you've done your mock, and then you are now ready. So during the mock, just also note that during the mock, we also take measurements. So the day we are going for your transfer, we already know where the embryos are going to be dropped. We have taken your measurements, and that's how you see when you are doing, when they are doing your mock, somebody will be saying 8 cm, 8 cm minus 1.5. They are doing calculation, they are doing mathematics. What they are doing is they are taking measurements so that on the day of transfer, we know exactly where the embryos will be dropped. And thereafter, your cyst drainage is done, and then you commence your medication. What medications are you going to commence on the day 2 or day 3? Antibiotics, anti-malaria, your vitamins, and then for those who we are stimulating, they will commence their stimulating agent. The protocol we use here entails that you start with folliculin first and buserelin. Folliculin is an highly purified FSH. It's part of there are different medications, all right? So different protocol. The one we use here, which is working for us, is the folliculin UMOG combination. And then you start your buserelin. For recipient patients, you don't take those injections, all right? You start with the extrafet, all right? Now, usually, sometimes you'll be told, don't start the extrafet today, the day you are starting your antibiotics, your anti-malaria. The anti-malaria is usually started after you have completed the antibiotics, okay? The folic acid, aspirin, and vitamin are started together with the antibiotics. And the antibiotics is for both you and your spouse. Why are we doing this? We just want to ensure we give this prophylactically. We're not saying you have infection, but just in case there's infection, it helps to take care of it. All right? And then you start the extrafet. Now, for women who are on endometrial regeneration, the day you start your extrafet determines when your next scan will be. because we want to know how you are responding to that medication. That medication is helped to build up your womb in preparation to receive your baby. And so what we are doing is that we are checking. So patients that are coming for scan, what we look out for depends on what program you are doing. If you are a self-patient and we are stimulating your ovaries, what we are going to be interested in is how are your ovaries responding, the number of follicles that you have. So even on the first day 2 of your scan, when you do your scan, we will count the number of follicles that you have. All right? And so we will start you off on the dose. Now, the dose of medication we start you off depends on a lot of factors: your age, your body mass index, all right, your test results. We will look at your test results, and then we look at any previous response you've had before. If you've done IVF before and we stimulated you and they say they got 40 eggs, 40 eggs, all of those things helps to determine what kind of program and what dose of medication we're going to start you on. All right? And then once we start you up, usually our starting dose is usually between 150 and 225. Maximum is 300. We don't go beyond 300. Why? We don't think it's beneficial. It's just a waste of resources and money if we go beyond, because studies have shown that we are very study conscious. We practice evidence-based medicine here, that going beyond 300 does not really help. All right? But what we want to do is to determine whether you are a high responder or a normal responder or a poor responder. All right? There are patients who have come to us, you are 44, and you are saying, I want to use my egg. We will counsel you. The thing we do is that we tell you that, see, these are the chances of achieving a good outcome. Because what we don't want to do is to take you through a program, stimulate you, and we don't get eggs. Or even if we get eggs, the quality of the egg is not good. All of those things will go a long way to affect the outcome of the program. All right, so usually you come in for your scans. For those who are on stimulation, you come on scheduled days for your scan. So after your day 2 or your day 3 scan, the next day you're coming for your scan will be after 4 days, which will be your day 6. That scan is just to determine if you are responding to our injection. After that day 6, you come on alternate day. Day 6, day 8, day 10, day 12. All right? And that means for day of stimulation is day 1, day 5, day 7, day 9, day 11. And this is for patients who are on stimulation. For patients who are undergoing endometrial regeneration, I'm sure you see me use 2 different words. Stimulation, endometrial regeneration. They are for 2 different kinds of patients. Stimulation is for those that we are stimulating them to use their eggs. Endometrial regeneration are those that are using an egg donor. All right? For those who we are stimulating, let me just go through that first. All right? We will check your ovaries to see how you are responding. And then we will also check the thickness of your endometrium, because we expect that if you are responding well, if your ovaries are responding well, your endometrial thickness should also grow, because your ovaries will be producing the hormone estradiol that will bring about the thickness of your womb. Okay? And then what is our end objective? What are we aiming to achieve before we say, we have succeeded? We are aiming to achieve at least 3 follicles that are minimum 17, 18 mm in size. And that's why you notice that for those of you who are going through stimulation right now, once they are scanning you, they are doing one measurement up and down like this. They are measuring those black things. Those black things you see Let me just take you. See those black stuff you see there? Those are growing follicles. Okay? You see, these are growing follicles. And what we do is each time you come for your scan, we are measuring those follicles to see if they are growing. There's a size that we expect on day 7 of stimulation it should be. If it's not up to that size, we now decide, do we increase your dose or not? Or you come and then the size is so big, more than what it should be. Do we reduce your dose or not? So the measurement that we do is to determine how you are responding and if we should increase or maintain the dose that you're on. All right? So usually, like I said before, standard dose 150 to 225. The duration of stimulation is for 12 days. Everybody, 12 days. However, there are some patients that will go beyond 12 days. Because what we want to achieve is that we don't want to achieve just getting eggs from you. We want to make sure the eggs are matured. Maturity is the major goal of stimulation. Because if you have 20 eggs and only 2 of them are matured, the only eggs you have are 2 eggs. Why? Eggs will not fertilize. If the eggs are not mature, they don't fertilize. And so we are very conscious of the maturity. And so once we are not getting the right size, we will keep extending your days of stimulation. So there are some people who will do 13 days. Some will do 14 days. Some will even do 15 days, 16 days. Why? Because we are trying to make sure that when we collect your eggs, the eggs are matured. All right? Now, it's also very important that as we are getting towards the end of the stimulation, particularly the HMG, the gonadotropin injection, and then the trigger, they are timed. So typically, your nurses will tell you the last day of your HMG, come twice. Or if it's the same time you are taking the buserelin, you are taking the gonadotropin in the evening, you can come once. But on the last trigger injection, you come twice. You come in to take your buserelin, and then you come in the evening to take the trigger. Why is it in the evening? Because of the time we do our collection. The collection is done 36 hours after your last trigger, after your trigger injection. If you do it way before 36, after 36 hours, by the time you get there, the eggs have already gone. They have ovulated. The body have released it, and you are not there to receive it. So that program is timed. And that is why when you are asking you to come for your OCRO, that is the oocyte retriever, you are giving specific time to come. Don't say, there's one party I want to attend first. After the party, I will come. Your eggs would have gone. By the time you come, no egg. What happened? Sorry, you came late. All right? And so the patient is given the time to come. And please, and very importantly, there's a test that is required for patients to do on the day of their trigger. All right? I'm saying it so that just in case the team don't tell you, go to the lab to do your progesterone test. Every patient that is going through stimulation, on the day you are doing you're taking your trigger injection, make sure you do your test, progesterone test. Why is it important? The progesterone test is important for us here because it will determine to a large extent whether we do a transfer for you or not. If your progesterone test, if the level of the progesterone level is high, then likely we will not do a fresh transfer. Why? Because we would have missed the window of implantation. What determines your window of implantation is your progesterone level. We don't expect it to start rising before we want it to. For any reason, it starts rising. it means that on the day of your transfer, the chances that you will get pregnant would have been reduced. And so we use that to determine whether you have a fresh transfer or not. All right? Please, I said that the antibiotics is for both the man and the woman. I'm glad we have men here. Please, cooperate. Make sure when the woman says, honey, says you take this, so say what? What? Are you telling me I have infection? My friend, don't. We are not saying you have infection. We are treating prophylactically. Just in case. You never can tell. Just in case there's infection, he starts taking care of it. Because there are sometimes the sperm, the man will produce sperm. You go to the lab, and then this thing will get contaminated. Once there's contamination with the culture, that program is cancelled. It will not result in anything. And so we fear infection like, all right? And then just for me to also mention this too, from the men, how you produce is also very important. All right? I'm not sure if we'll get to that, but let me just say it. When we ask you to produce, the best form of production is through masturbation. Fortunately or unfortunately, some men are not able to do that because of their upbringing and how they've never done it before. So it usually becomes a challenge. Some men cannot produce until they've met with their wives. And so some men may want to do coitus interruptus, meaning that you break and then you come out. And the problem with that is that sometimes there could be contamination. Once there's contamination, it affects the lab. All right? And then there are some men who also have challenge with producing outside their comfort zone. Please let us know. If there's a challenge with production, let the team know so that you can produce way before that time and we'll freeze it. Once you tell a man, today you're going to produce, he just goes into panic. Hey, today. Let me start preparing. He starts to prepare. That day will come, anxiety has come. Do this thing. Madam, you don't understand. My body is not responding. To curb that, please, it's important because we've had this experience and sometimes programs are cancelled. Because if we have eggs and we don't have sperm, we can't do anything. The eggs will just go to waste. So please, let's be sure. If for any reason you think that could be a challenge, let us know so that we get it before that time and just keep it. That can serve as backup. On the day we usually will prefer the fresh sperm. So that can become a backup. For any reason something happens and we are not able to produce that, then we fall on the backup. All right? So we've talked about the medications that you have to take. And then we've talked about the dose. And then sometimes we can increase. And then we change the dose from folliculin to Humong, either on day 7 or day 9, sometimes day 11, depending on the profile of the patient. So sometimes you may see that you are taking this particular injection, and after a while, they're now asking you to take this other injection. Just know that we used a combination, and then we can change. Okay, this is what we expect to see on scan when the follicles are growing. All right, and then it's still growing, and once we've gotten to the size, all right, then we give that injection there, the HCG. That is the trigger injection that brings about the final maturation of the eggs in the follicles. And then 36 hours after you take this last injection, you'll be ready for the oocyte pickup. So note that the time you take this last injection determines when your collection will be. So if you're supposed to take the injection 7:30, and you come in 8 o'clock, you have only shifted your time for collection by 30 minutes. All right? But let me also state that sometimes, because of the pressure of work, if we have more than 1 or 2 patients that are doing collection on that day, if we extend by 30 minutes, 1 hour, there's no problem. So don't go into panic mood. I say, they said this time is when my egg must be collected. Now it's 30 minutes after. I hope my eggs have not ruptured. No, relax, be calming down. Nothing has happened. Okay? Now, for those who are on endometrial regeneration, who are using an egg donor, you're going to go through, so yours is a bit easier in terms of the pain, let me put it that way, that you feel, because there are no injections. What you are taking is just tablets, all right? You're taking the estradiol to help to bring about the development of your womb. And what we are interested in for women who are going through this is just your endometrium. You see that, this there? What we call the triple line echo, 1, 2, 3. This is a very good picture. When we see this in a woman's scan, we say, we're happy, because very likely pregnancy is going to result. And we expect that as you continue to take that medication, that endometrium begins to get what? Thicker and thicker. So they usually will ask you, come every week. So unlike this stimulation where you come after 4 days, and then after other day, every other day you come. For those who are going through endometrial regeneration, you come weekly. Yes, it's not so. The number of times you come to the hospital are less than those who are going through stimulation. So you don't say, my friend is coming to hospital more than me. What is happening? You people have forgotten me. It's not true. It's not true. It's just that your programs are different. All right? And this is what we also do for patients who are going to have frozen embryo, or call a frozen embryo transfer. So there are patients who would have gone through that, the first stimulation, and they have embryos that have been frozen. If we want to take them, transfer those embryos, they just go through this process of preparation of the womb. They don't need to go through taking any injection. All right? So on the day of oocyte retrieval, patient is told, given some do's and don'ts. The nurses will counsel you what to do, preparations and all, the whatnot, no perfume, no deodorant, douche, come in 30 minutes before the time, no breakfast, because it's done under anesthesia, all right? Because we don't want you to feel any pain at all. So it's actually done under general anesthesia. So you're not supposed to come in, you're supposed to come fasting. It's not a long process, so the time we actually use in collecting the eggs depends on the number of eggs that you have. For those patients who have far more eggs, they spend more time during the process of the pickup, all right? And then after the pickup, you are recovered, and then within 30 minutes to 1 hour, you are fully recovered. We advise that women who come for oocyte retrieval should not drive. So that means the husband should come, bring you and take you back, or you make sure you organize for, yes, a pickup. If you must drive, that means you must stay with us for hours, maybe like 2, 3 hours, 4 hours, to ensure that you are fully recovered before you go home. Also to note that on the day of your pickup, you will start your injection, the gestone injection. All right, also note that please, after you've had your pickup, if you've not started an injection, ask why. All right? Patients who will not take injection at all are patients who we have already determined that they are not having fresh transfer. All right? And then for embryo transfer, we do the 5 embryo transfer. All right? The 5 embryo transfer is what we do. All right, some people, so occasionally we do the 3. If we have to do the 3, it means that we don't have so many embryos, and there's no reason for us to now start waiting till day 5 to select the best. The advantage of a day 5 transfer is that it helps you to determine which the best embryos to transfer, because they have grown and you are seeing the ones that are doing well. For day 2 or day 3, you may not be too sure. You may think this one is growing well, but by the time it gets to day 5, may not be the same. All right, so we normally would do the 5 transfer. Now, the time for the transfer is communicated on the day of the transfer. So if you call the nurse and say, nobody have called me, they've not told me when I'm coming for my transfer, they won't call you. Why? Because they don't even know. On the morning of the transfer, the embryologist will go to the lab, check the embryos. Now we do a continuous culture. From the second day after the insemination, when they check how many are fertilized and they put them back, they don't check again until the morning of the transfer to know how the embryos are doing. It's not the one that you say, okay, this is my baby, let me go and check and see. They bring it out, check it, and then they put it back. Oh, tomorrow, let's see. No. If you do that way, the embryos will not grow well. All right, so you want to make sure that the embryos are doing well. So we do the continuous culture. So once they have put there, the only we can tell how the embryos are doing and when the transfer will be on the morning of the transfer. So expect a call from in the morning as to the time of your transfer. But most times, our transfers are usually in the afternoons. All right? Are usually in the afternoon. So for those who have transfer on a Sunday, go to church. It won't disturb you. We will not call you from church, say, madam, please come, your embryos there. No. You can go to church. All right? But typically, you will get a call from the nurses on the morning of the transfer. And usually, they would have told you, all right, the do's and the don'ts. Again, no makeup, no perfume, no deodorant, just wash, douche, and then you come. Our transfers are usually done under with some water in the bladder. Not your bladder very full. If your bladder is very full, you'll be uncomfortable. And most times we may want to drain and remove some of the bladder. So just some cups of water. Some patients will finish those bottles, finish like 2 or 3. And then if there's any delay, they just keep going to the toilet. I say, not too much, okay? Just to have some urine in your bladder and you'll be good to go, all right? And then you have your transfer done. It's also very important to know that, okay, now that we're not doing the sperm collection in the IVF lab, so we don't really have that challenge. But if we were doing it there, then what applies to the man also applies to the woman. No perfume, no deodorant, nothing. Like I said before, it's very important how you collect the sperm. Don't use any scented, cream, all of those things. Avoid contamination. Once it's contaminated, it will be a challenge for us. Okay? And then of course, the team will do that. The proper labeling of the sample would have been done before they hand it over to you. And please, when they hand over to you the container, check that it's your name that is there. Because if they give you a container that is not your name and you go produce into that thing, there will be what? A mix-up. I'm saying this to you. We will do our part. I've not had that experience. Nobody has complained that this was what happened. But please, I'm saying it here. All right, please, all our patients, make sure when you are giving the sample bottle to produce into, the first thing you do is confirm that the name is your name or that of your wife. All right? So that we are sure that when it is produced, it is used for you. Okay? And then the transfer is done, and then patient is expected to be in 30 minutes before the scheduled time. Let me apologize ahead because I know it will happen. Sometimes you may need to spend more than 30 minutes waiting for transfer. We sometimes say, this is the time we want to start, but sometimes we don't start at that time because of a lot of factors, which I may not want to go into. So I'm apologizing ahead that when you come, be ready to be very patient, but we will try to make sure that we don't prolong the time. All right? And after you have, now, for patients for our recipient patients, you start your gestone injection the day after. You know, I mentioned for people who go through stimulation, on that day of the stimulation, where the eggs are collected, you start your injection. For those who are recipient programs, you start your injection the day after. not the day after the collection. The next day, they will call you to come and start your injection. So you actually will take that injection for 5 days. For those who did simulation, they start the day of the collection, they take it for 6 days. 5, 6 days is the same thing. It doesn't matter. But the reason why we call you a day after is because we want to be sure that there's fertilization. Because if there's no fertilization and you have started your injection, the program is finished. Because it is when you start your progesterone that determines that committed step, that committed stage. If you don't start progesterone, we can roll you over. We can extend your program. Remember, we said you are on down regulation. You have taken an injection that gives us control over your body system. So we can move your program ahead and then still do another program for you. And then once we are sure, you start your injection. So your husband has come, I've done insemination. Don't say, I've not started injection. My friend that came with me, she said she took gestone injection that day. Nobody has called me. Again, like I said, don't compare yourselves. Your programs are different. All right, so I'm just saying that. And so you start the following day, you take for 5 days, and take the last injection on the day of your transfer. And then after your transfer, again, you'll be given some medications to take for 2 weeks, and then you'll be told, in 2 weeks' time, you come for your pregnancy test. Pregnancy test is done 14 days after your embryo transfer. What are the do's and don'ts? Can I go to work after my transfer? Yes, you can go to work. Should I stay at home throughout, hang my leg on the bed, and not move anywhere? No. Don't go and, can I take my bath? Yes. Can I cook? Yes. Don't starve your husband. Now, what is stressful work? That is, now let me tell you, what we consider as stress is what affects your psyche, your emotions, psychological. It is those psychological. So if your work is such that it drains you psychologically, then you can take a break. Because that is what affects, but not activity. Oh, I cannot go out. Oh, I cannot go to, no, you can go. After all, those who get pregnant, they don't even know they're even pregnant naturally. So it doesn't affect. Yes. Yes, you can travel. Oh, yes. Not long haul, but not by road. Why? Not that you can't travel by road. Our roads are not good. So if you're going by air, no problem. Long hauls out of the country, why not? But you're not the pilot now. Even the pilot itself is auto fly. They just stay and be taking coffee, and the plane is flying. Drive. You can drive. I don't see any reason why you can't drive. Basically, you just go on with your normal activity, with your normal life. Nothing. See, and we have discovered that when you go to when you check, they will tell you that bed rest does not affect success, and that is the truth. Sometimes when we tell people, say, oh, just see at the rest, this and that, we are trying to work on your psyche to make you feel more comfortable, but it doesn't affect. Do you understand? So, in fact, rather, it may even worsen it. Because what we've discovered is that the 2 weeks you wait between when transfer is done and when you do your pregnancy test, they are the most difficult 2 weeks of the whole process. Your mind is running up and down. Hey, what will happen? Will it be positive or not? Everything that happens to your body, you will notice. You see one small pain, this pain. Honey, please, go. This thing, pay. That thing happens normally, you don't feel it. But because, I've had transfer, nothing must happen. No. Any small thing, you feel it. But when you are walking, you get distracted. So you won't even know that you've had anything. Just that you need to take your medications. So we say for those of you who travel, who have to get up early in the morning, who do 9 to 5 jobs or 8 to 5, get up early. Because when you're told that when you're taking your cyclogest insert, you put it and then you lie down for 2 hours. So you know when you normally should wake up to start getting ready for work. So if you're the type that wakes up by 5, so by 3 when you just time yourself, by 3 you wake up, go and eat yourself, and you put it, go back to sleep. 5 o'clock, you have done the 2 hours, and then you get up and then you can get cracking. And then in the evening, you come back and then you put it. All right? So that's it. So, what kind of food can I eat? Your normal food. Okay? Just ensure that you eat healthily. Fruits, a lot of fruits, vegetables, plenty of water, but avoid sex. So just tell Oga, doctor said, Oga will understand. So sometimes this avoid sex can become longer. Let me just say it now ahead. From 2 weeks, 2 weeks can become 6 months. It can become 9 months. Oga is not around. So when they start saying, sir, when can we resume? Or guys, I say, see. Truly, why? Because let me explain to you why it can become 6 months. So we say for the first 2 weeks, nothing. No, there's very few things that we try to say, okay, there are restrictions on. This one is one of them. So we tell you, okay, first 2 weeks after the transfer, nothing. So the person says, okay, 2 weeks, nothing. Now, once you get pregnant, it automatically extends, right? Because you don't want to get pregnant and then you are now meeting and then, because the semen contains what we call prostaglandins that can bring about some subtle contractions. And then you're not also sure about infection and all of those things. You don't want anything going around that place at all. The process has not been easy. So we say, okay, let's wait till after the first trimester, which is how many months? 3 months. Now, for most patients who get pregnant through IVF, after 3 months, we'll not tell you come and do cyclage. Now, after cyclage, you don't meet again for another 2 to 3 months. How many months is now done? 6 months. Then at that 6 months, my mother says, see, you just leave me. Let's just wait till after this 6 months. My body is not in a frame of mind to begin to do this thing. Now I say, okay, till delivery. How much? That is how many months? 9 months. Then after you deliver, I say, you can't just deliver and now begin. And my body needs to come back to normal. So give me another 3 months. That is how much? So that's what I said there. This journey can be up to 1 year. But it is for a good cause. That means the person needs to find someone. Okay, I can't answer that question. No, it's agreement. It's agreement. Now, what it's agreement. It's just to say, okay, just ask God for grace. Just ask for grace. Okay, so that is that. So apart from that,
is it months?
Okay, is it compulsory that you do cyclage? Now, this is our take. It's not compulsory. Let me just answer it plainly. But I often will ask the patient, have you carried a pregnancy before to 9 months and have delivered? He says no. So okay. So this is the first time you're getting pregnant and you're getting to 12 weeks. Now, because 5 to 10% of patients or women have what we call incompetent cervix, that means their cervix is not strong enough to carry a pregnancy and remain close till 9 months. So I ask myself, do I want to take this woman through this risk? I don't know whether she falls among the 5 to 10%. Because the only way you can diagnose incompetent cervix is if a woman has had it. You've had a miscarriage, mid-pregnancy miscarriage, 20 weeks. And I don't want to use this pregnancy to test whether this woman's womb is okay or not. So what is the best thing? Just prevention is better than exactly. Just put it there, just in case. So that is why we end up doing it for virtually all women who go through the IVF process, just to make sure and double sure. But once you are carrying multiple pregnancies, 2 or 3, then that one is more important. Because even if you have carried 1 pregnancy before, you've not carried 2, you've not carried 3. And so usually we want to put a circlage. All right. So avoid potash. All right. So all of you that like the quad B, all those that you add this thing for now, just avoid it. All right. And then after that, 2 weeks time, we expect you to have 2 lines. All right. And I would say congratulations. And yeah, so you book an appointment for 2 weeks. For those of you who are not based in Abuja, when you do your test, please send us the results. Okay, we will call you to find out what the result is, and then we will give you the necessary counsel. If you are positive, you will commence your luteal support immediately. And if you are negative, we will counsel you, and then we'll tell you what the next step is. Now, for those who, whether you are positive or negative, 2 weeks after that test is done, something must happen. For those who are positive, you will come for your next scan. You come for your scan, your first scan, to determine how many babies you are carrying and the viability. And for those who didn't get pregnant, you will come 2 weeks after for a counseling session. Because we know it's not easy. To go through a failed IVF program is not easy. So we'll counsel you, and then we'll tell you what the next step will be. But let me just say this, and that is the direction we are moving into. To say that while we expect and we hope that all of our patients get pregnant in the first cycle, but in reality, it is not so. In human reproduction, God did not make it that once you go through a process to get pregnant, 100% of the time you'll be pregnant. And that is why even in natural conception, the chance that a woman, super fertile couples, young couples will get pregnant is 25–30%. But every month, that chance keeps increasing. And then after 6 months to 7 months, majority of the women who have no problem would have gotten pregnant. So when you are coming for an IVF program, all right, to help your psyche so that you don't completely lose it when it doesn't happen the first time, prepare. And that's why it's not what patients want to hear. Patients want to hear that, I don't want you come, man, first time you just get pregnant. Yeah, we try to be very realistic. We went through IVF, did IVF 9 times before we had our twins. A lot of you will now have to go through 9 times, all right? But what I'm saying is that it may not happen the first time, but we do our best under God, and we trust God to ensure that the majority of people who go through the program the first time will get pregnant. But there are some who may not get pregnant the first time, even the second time. Why? Because the profiles are different. The medical challenges that confronts different couples are very, very different. But what we can assure you that if you don't give up, and if you don't lose hope, eventually, and you are open to all the options that are available, eventually you will end your journey as a success. So, thank you very much.
Most of the people that are having challenges of fibroid.
Yeah, those who have challenge with fibroid. So fibroid is a very common phenomenon in women who are going through infertility. So when you come in initially, we will assess you, and we will determine whether that fibroid will be a challenge or not. Sometimes it's very difficult to say, because we have seen women with fibroid get pregnant. Do you understand? So what we do here is that depending on the size and the position and the number, we can counsel you outrightly that, see, you need to remove this fibroid before you start your process. But if we think that it is not going to stand on the way, we will allow you to go ahead. Now, if it's the type that is not so clear, what we normally do is to say, okay, let's go through this program first and see. Because the truth is that most patients are not even willing to go through surgery. So they want to be very convinced that, yes, truly, they need to go through surgery. All right? So we will allow them go through that surgery. to go through that process, have their first cycle of IVF. And if we determine that the only reason why this woman is not pregnant, having looked at all the different factors, is because of this fibroid, at that point, we will ask you to go for the fibroid surgery and take it out. All right? So it depends on what we see at the beginning. That will determine what options we take. Okay? Okay, questions? Time for questions. Yes?
Is there any other way without going for surgery, maybe injection?
Yes, there are injections, but truly, I don't advocate that injection for a woman who wants to carry a pregnancy. Why? Because taking those injections does not particularly help because of the size and the position of the fibroids. Because what those injections do is that they just try to shrink the fibroids a bit. But once you stop those injections, the fibroid just grows back, just continues. And before we would tell a woman go for surgery, it means that they're not just small fibroids. The fibroids are big. So the best thing is to take out the fibroids, all right, and get the womb prepared to carry pregnancy. So I know that most women don't want to go through surgery, but the truth is that surgery is for me is the best option if you want to get pregnant. All right.